Good afternoon, everyone. This is Morgan from the New England QIN-QIO, and I wanted to thank you for joining us for today's interactive webinar on acute change in condition with Carol Dietz, Sheila Eckenrode, Florence Johnson, and then we have a few special guests here today as well. Before we get started, I want to review a few housekeeping items. This webinar is being recorded for training purposes. We will provide you with instructions on how to access the recording at the end of the webinar. Phone lines are on mute for the duration of the presentation. We will be taking questions at the end, but we will let you know how to unmute your line at that time. And I also want to let you know we have been having some phone difficulties today. We're not sure if it's due to the weather, now that we're finally getting rain, or if there's something else. But if the line drops, if you could please try to call back in. We're crossing our fingers it doesn't happen, but, you know, technology doesn't always agree with us. But if necessary, we will reschedule this webinar, but again, we're recording it, and if we need to reschedule it, we will. So with that said, I will pass it over to Carol to get us going.
Good afternoon, everyone. Welcome, welcome. What a beautiful day. We finally have gotten the rain, as Morgan just said. And this is our 9th session, and today we're going to be talking on the decision support tools within the Interact program, the Interact Quality Improvement Program. As Morgan mentioned, I am Carol Dietz, and I'm one of the quality improvement consultants here at Qualidyne, which is part of the New England QIN-QIO. And I'm so excited that we have special guests this afternoon, but I'm going to have my colleagues introduce them, and it's going to be an outstanding hour. Hang on to your hat. Before I go on, I just want to remind everyone you are on mute, but just to make sure that there's no interruptions, please put yourself on mute, and please don't put us on hold. That music really has driven us up the creek sometimes, so please do not put us on hold. So, as I always do, I always want to talk about my sister states. And my colleagues working on the Interact and the care transitions work in each of the states. As I mentioned, I'm Carol Dietz, and my colleagues Sheila and Florence are here. Our team lead, and I've never introduced her, and I have been remiss, is Ann Elwell. She is our leader in charge and just a wonderful team lead, project lead. In Rhode Island, it's Kathy Calandra and Neela Odom. In New Hampshire, Joyce Johnson, Margaret Crowley, and new on board is Tim Boyd. And Vermont, it's Liz Kepner and Gail Colgan. Massachusetts, it's Lynn Case, Shara Leahy, and Lloyd Nirbon. And in Maine, it's Maureen Leahy. So again, these are my colleagues and throughout the New England QIN-QIO. So today's session objectives. I've just welcomed everyone. Hopefully you will get a better understanding of how to use the Interact Acute Change in Condition file cards and Care Path, which are also known as the Decision Support Tools. You will get a good idea of how to develop a plan for implementing the Change in Condition file cards and Care Paths on each of your units within your facility. Understand the importance of using the SBAR tool when reporting a change of condition to the physician, APRN, or PA, and also during an acute care transfer. And then at the very end of our hour, the last 15 minutes, we'll have state-specific group discussions as we do each month, and I'll have more information on that once our content program is complete. With that being said, I'm going to be turning this program over to Sheila Eckenrode, who is starting off with our famous polling question.
Good afternoon, Interact partners. I'm very pleased to be with you here today. As we do every session, I'm going to ask the same question. This is our way of measuring the penetration spread of Interact. So if you can take a minute to answer this question. The facility has started inputting data into Advancing Excellence, the Interact Readmission Tracking Tool, the Interact Readmission Tracking Tool using a paper tool. Are you using another readmission tracking tool, or have you not started tracking readmission data yet? And I very much appreciate you just answering that question and being sure to press the submit button. Take a few seconds to get those results.
Emily and Jennifer, are you guys on the line? Can you open the polling question, please?
Okay, we'll move along. So far we have talked about 3 of the 4 domains in the Interact Quality Improvement Program. We've talked about the QI tools, the quality improvement tools, such as the readmission tracking tool, which provides us with data on our readmission rates and some drill down information as to where readmissions are originating from in the facility. It will help us look at readmissions by shift, by day of the week, by clinician, etc., and hopefully you're tracking your readmissions either using the Interact tool in Advanced and Excellence, or a tool maybe provided by your corporate parent. We talked about that quality improvement tool. We've also talked about the root cause analysis tool back a few months ago, and that is the tool that you use to sort of do a deeper dive into the causes and contributing factors to an unplanned readmission. We've talked about the communication tools, the internal SBAR and the external SBAR. We've talked about Stop and Watch, which many facilities seem pretty enthusiastic about implementing. We talked about communication tools across the continuum, such as the transfer form and the red envelope and the SBAR for external communications. Last month we talked about advanced care planning tools, and as I mentioned last time around, I think advanced care planning tools, or advanced care planning in general, is something that long-term care facilities usually do very well. But I would encourage you to look at the advanced care planning tracking tool in Interact, because it's a way of documenting how frequently the conversation about palliative care and comfort care occurs for a particular resident. I know we're usually really good at doing that on admission from the hospital, but very often there's some changes, a month or 2 down the road, and the conversation hasn't occurred again. So it's a way of tracking that and who's discussed palliative care options with your resident and their family, when that conversation has occurred, and it can be used to prompt that conversation again. Or, maybe you want to hardwire it into processes in your facilities, such as, quarterly resident care conferences, a good time to talk again about care options for the resident and their family. So we talked about them, and there's a communication guide on how to start this conversation that many people find very helpful. It's a difficult conversation to start, so there's some good tips in that. So that brings us to the last domain, which is decision support tools. So the decision support tools provided by Interact are really 2 things. One is the acute change of condition file cards, and the second are the care paths. And these are designed to provide staff with evidence-based best practices. I really encourage you to download these, or at least open them up today if you haven't seen them already, because I think you'll be quite pleased with what you see there. So let me talk a little bit about the acute change in condition file cards. Basically, what these are cards that prompt clinicians to call an MD or APRN immediately versus let something go to the next licensed independent practitioner rounding. So immediate notification serves as any symptom, sign, or appearance of discomfort that is acute and sudden, a marked change, or unrelieved. Non-immediate notification of new or worsening symptoms that do not meet the above criteria. So that seems pretty easy to do until you put it into practice. So these cards are very specific, they're very concrete, and they're going to provide guidance on when to communicate acute changes in a very concrete way that especially new staff can find reassuring. Very simple, they're easy to use, they're easy to read. They're alphabetical order. They start with abdominal pain and end with wounds, things that we see every day. We recommend that you place them at the nurse's station or on med cards, laminate them for quick references, and our guests today will tell you how they implemented them. Very helpful, and as I said, a good orientation tool for new staff. And know that because these represent evidence-based best practices, they're ready to become your policy and procedure right there. You don't have to alter them in any way. You can say, this is what we do, and you will find that they'll be in compliance with the state and CMS guidelines, and then to notify physicians and APRNs. So I encourage you to look at them. Really easy. I'm just looking at my notes here. Here's a good one. The symptom is appetite diminished. When does that require immediate notification of an MD or APRN? If there's no oral intake for 2 consecutive meals. Non-immediate, significant decline in food and fluid intake. So it gives the clinician on the floor, the nurse on the floor, some confidence and backing, because as we know, being a registered nurse or licensed nurse in long-term care can be kind of a lonely post. There's usually only one per floor, so this gives folks some confidence that they're doing the right thing, a little memory jog, if you will. The other thing that Interact is offering us in terms of decision support are care paths. And again, I really encourage you to look at these because, again, they're evidence-based best practice. They can become your policies and procedures right out of the box. You don't have to do anything else with them. They're very helpful for new graduates, for the orientation of new staff. So I know that this is a bit of an eye test, but I'm just going to walk through this very briefly. So this is the care path for mental status change, which you see a lot of in long-term care. We see a lot of it here in Paradigm among my colleagues. They usually have an episode of acute mental status change at least 2 to 3 times a week. So what do we do next? You notice the acute mental status change, you take vital signs. All right? The next part of this decision tree is what constitutes abnormal vital signs that require immediate attention from an MD. So yes, that criteria is met, you notify the MD. No, the vital signs are stable. Now you're being prompted to do more of an assessment. And I just want to kind of draw your attention to the way that this mirrors the SBAR, because people will say, I have to go back and I have to fill out this SBAR and it's taking a lot of time and we're in a great hurry. But if you walk through a good nursing assessment, you're going to find that you're filling out the SBAR as you go. So, S. What is the presenting symptom? A mental status change. The assessment, we're looking at vital signs. We're looking at other signs such as cough, abnormal lung signs, sounds, diarrhea, a new skin condition. And again, the tree is going to tell you which one of these things require immediate notification of an MD or APRN and which can prompt you to do a little bit more evaluation. So, towards the end of this decision tree, you're going to see suggestions for orders, which is the R of our SBAR, right? So for acute mental status change, maybe portable subject rates and blood, etc. You can write on this care path. It's going to tell you what values should prompt more aggressive treatment versus what can be managed in the facility. So download these, show them to your staff, chat them up, see what people think. But again, this is a great tool, especially for less experienced RNs. So I thank you for that attention, and I hope that you will look at these because they're pretty good. And with that said, I'm going to let my colleague Florence introduce our guest speakers.
Good afternoon, everyone. Thank you for joining us. I am very excited to have in the building with us today
team members from Caleb Hitchcock Healthcare Center at Doncaster, which is a 60-bed facility in right here in North Central Connecticut. LaShawn Wilcoxon is the Director of Nursing at the facility, and she and I met about a year ago. She called me and wanted to really dive into Interact, what it is, how their facility can begin to implement it. And I am so excited that she called me back a few months ago, and I went to the facility. I was totally blown away by how much they've implemented, how well it's working, that I came back and I told my team here that we have to have them speak on the call about the work that they've done. And we're very appreciative that they were able to take time out of their busy schedule today to come share with you. So I hand it over to Leanne Shaw Quinn, APRN, that has helped to further the work in the building.
Thank you, Florence. First of all, I'd like to thank the Claudine team for including LaShawn and myself in this presentation. I'm very excited to share our process for the introduction and implementation of the Interact or SBAR process at our facility at Doncaster. I think it's helpful to briefly share what has inspired me to become involved in this initiative. As an APRN, I function from the perspective of two worlds, both medicine and nursing. Before becoming an APRN, I was a staff nurse in acute care setting for over 20 years. One used to say that I was a part of the nursing team that was in the trenches. So I'm very passionate about empowering the quality of care at the bedside, at the level of the staff nurse. Another thing I'd like to share is my interest in the mind-body connection. I have experience, I'm trained as an energy practitioner. And this kind of lends well for us as individuals, but also to kind of translate these skills for taking care of our patients. I have training in Reiki, Tibetan singing bowls, and now mindfulness. So I wanted to start the presentation with a slide that says, Empowering Nurses to Interact, a fun way to bridge the gap between theory and practice. So as I went along my journey to work with staff nurses, I want to kind of set the tone, kind of raise that vibration, and to be in a very safe, nurtured environment. One that is, puts one in a position for better learning. So I actually brought my singing bowl with me today, and I will do a little demonstration. I'm just going to sing the bowl a little bit. Might be a little harder to hear. And so the goal of one of the things we are energy surrounds us. Kind of gets rid of any kind of negative energy. Kind of help us be in the moment. To take a couple deep breaths. And it kind of opens our brain to accept new learning. Because when you're in the moment, you're not thinking about what you had for lunch, what you have to do next. Being in the moment so that you can receive new information. So it's important to be in an environment that is judgment-free. One thing in this setting is to appreciate that everybody has their own reality. There is cultural diversity. The nurses in the room have different experiences and training. And so this way, hopefully, we'll work together as a team to learn a new concept. It's often a good idea to step outside of the box to view situations from a different perspective as well. On the background, when we're talking or working with nurses, some of the theoretical constructs that we want to take into account is the change theory. And we talk about pre-contemplation, contemplation, action, completion, and review. I say in order to change those behavior, it takes about a month or so really to make those change a part of who you are and continue on. One of my favorite nursing theorists is Patricia Benner. She talks about working with nursing students, working at them from the novice to the expert. And as I look at the Interact tool, it is perfect for the novice nurse, for the new grad, because the new grad functions from rules that are not conditional. As you get more experience, you can kind of tweak the rules a little bit, and you have something to build onto. As you reach more of the expert nurse, you have more use of intuition in your thought process. The research that she did showed that there is a distinguishable difference in the novice to expert description of the same clinical incident. Another way for promoting adult learning is case studies are very helpful. So as we bring out this Interact tool, it's really fun and exciting to actually work on case studies in an environment that is safe. Mentorship and supporting each other in the group process is also an important component. One thing I wanted to do, as I brought the SBAR tool to present to the nurses, I brought a painting from a book. And I had the nurses, this is a painting, this is Claude Monet, called The Bench. And I had the nurses look, and I said, what do you observe about this painting from the point of view of a nurse? And I think as a nurse, I think we were probably looking at the expressions on their faces. I was kind of thinking, is she annoyed? Or, what's going on here? The guy seems to be kind of bothering her. But I was also able to share from the point of view of an artist. There was a whole page describing the colors and the flowers in the background. So it really kind of sheds light on, you look at a picture and there's different things that different people are going to observe. Much like looking at a patient. You have a novice nurse look at the same patient, they will see something different than an expert nurse. So again, I think the tool will be wonderful to kind of bridge that gap. So what I had the nurses do is again, to start the observation. Next slide. Again, I provided the case study. That's like what Sheila was saying. I provided them with two groups of nurses working as a team, provided them with a case scenario. I provided blood work, vital signs, a discharge summary. Then I gave them a scenario, for example, acute shortness of breath. And I gave them some time to work as a team to fill out real time the SBAR and the Interact tool. And that way they can work together with their different points of view, sharing information. The next step is what I wanted them to do is take that tool and come up with a 30-second summary of the SBAR. From the point of view of medicine, oftentimes what happens is we're on the other end of the phone and we get a call from a nursing home, and oftentimes we'll get a call that says, this patient's short of breath. And we're kind of looking for our input. So the reason why I really wanted to work with this is to using the tool, giving the situation, the background, the assessment, and the recommendations before calling. This way, the picture will be painted to the other person on the other end of the phone, and the provider will know what you're talking about, so that clinical decisions can be made that make sense, for the patient. So what I actually did is, after they came up with the SBAR, I actually went into another room. I had one of the nurses call, and I was on the other end, and so real time, I was able to, describe to me over the phone what's going on using the tool. And I was able to share kind of the picture that they painted over the phone with them to kind of further kind of instruct and discuss, ways of improving. Next slide. I came across a quote from McClure 2005. It said, the utility of the concept of skill acquisition lies in helping the teacher in how to assist the learner in advancing to the next level. And another thing that, Benner said, that studies show that skill acquisition of student nurses found that developing competency requires practice in a clinical setting that provides safe, structured learning with role-play simulation. So in conclusion, basically, being in the moment to receive new information, the group process, mentoring, critical thinking, case study with a simulation exercise, you want to review, reflect, and revise. The overall goal is to inspire nurses to develop critical thinking skills with the use of Interact tools, and hopefully this goal will become a reality. This will lead to better patient care, better outcomes, decreased length of stay, and decreased hospital readmissions. Thank you.
Thank you so much, Leanne. Now Sean's going to tell us how Interact was implemented at the Caleb Hitchcock Health Center at Doncaster from an organizational point of view. But thank you so much, Leanne, for that insightful information and description of how people learn. I think that gets lost. Very often we send out information and we expect it to be received like you might throw seeds on barren soil. So thank you for that. All right, LaShawn.
Hi, my name is LaShawn Wilcoxon. As was said before, I'm the Director of Clinical Services at Caleb Hitchcock at Doncaster. And one of the things I wanted to discuss is how we were able to roll out the Interact at Caleb. And the first thing I wanted to look at is why. Why roll out Interact? A lot of times we get inundated with a lot of information. And one of the things that we found that we were excited about when we went to the first training, we wanted to improve the communication among the multidisciplinary teams because we're CCRC. For those who don't know, that means we have continuing care. We have those who come in independent. Then they may transition to assisted living. They may come over to the health center as a rehab patient, meaning subacute, or they may actually move in with us living in the long-term care, or they may transition to dementia care. So you see we cover all facets. And one of the big challenges is that we're following this resident or throughout the community. So they come in independent. We were challenged and presented with how do we keep this person safe, and if this person is independent, sent out to the hospital, readmitted, to actually build on that communication. One of the things we did was develop a transition team, and how to interact, work with that, is that we identify high-risk residents. We wanted to improve the clinical decision-making. We wanted to improve the resident, the staff, and the physician satisfaction. And we wanted to decrease potential avoidable emergency department evaluations or hospitalization of the Doncaster residents and patients. And the reason I said residents and patients is because our residents and our patients may go back to independent living, while we also have residents and patients that come from the community. So we would have someone go back to their home, which is on campus, or we may have someone discharge out back to the community. One of our goals for implementing this was that we wanted to make sure that we went across the continuum. But we had to look at this, because this was very daunting. When you look at this big picture of this, we were excited, but how can you actually implement all of these parts? And we began to look at this, and we broke it down into parts. We found that was the best way, by taking a big picture, a big project that we had to do, but actually make it into small parts, biteable parts that we could ingest. And the first thing we did was the training. We saw that we could do that by having the training, making sure that the nurses were trained, and that's where Leanne came in. And Leanne didn't tell you, we had fun with this. She came in, and the nurses, we first gave a call to her, and we did it the normal way we would normally call the doctor. And then the second way, we had to make sure we utilized the S-bar and calling, and she critiqued us. And then she did it in such a way that the nurses and I was very receiving of that information. But it helped the nurses also to empower them when they called the doctor to give this information. The other thing we did was, it was presented by our senior VP to the annual board members to bring them aboard. So we brought them aboard. We brought it to our health advisory board at the meetings. We made sure we met with the families, because we wanted the families to be involved. A lot of times we're rolling out programs and you forget to involve the families. And so as I go through to tell you about the parts, we'll bring back up the families. And then, as was before mentioned, we had the APRN, which shows the collaboration with long-term care in the hospital, because Leanne is that liaison as she works at the APRN with Hartford Hospital. So we broke it down into 3 phases. Phase 1, we looked at the stop and watch early warning tool. We looked at the care path, acute changes, condition file cards. We had the SBAR forms and progress notes, and the hospital communication queue. Phase 2, we continued with the hospital communication tools. We included the transfer checklist envelope, the transfer data list, and the sample forms. And then in phase 3, we brought in a medication reconciliation worksheet and the advanced care planning tools. Now let's look at phase 1. And you may look at the Interact tools that we received from Interact in everyday care and say, well, they have it set up a certain way, but we see that you didn't follow it the exact way they had for the list. And the rationale behind that is that because we were including the families and we wanted to make sure they understood the stop and watch. So we took the stop and watch first, met with the families, and went over it, so that they could be empowered. How many times have a family or someone, the family, the housekeeping, dietary, the receptionist, we wanted those people to understand what the stop and watch was for, so that they could have this information, and if they didn't see a nurse, they could circle it. We made a stop and watch box so that it was throughout the campus, and that they could we send it to a printer. We had to make up the cards for us. so that they could implement, they'll put those into the box. It was secure, so we didn't have to worry about HIPAA. I know people would bring that up. And the nurses and the supervisors had a key, and that they would check those boxes each shift to have that information. So that's why we started with first getting it to them so that they would have it. The next thing we did was, at the same time, was the S-bar. We had the S-bar, but we utilized the S-bar along with the care path, and we had the cards made up that we're talking about today to assist the nurse that as they completed the S-bar, that they would have the tools to complete theirs. One of the things, it is an ongoing process. So now we're at the stages where the doctors and the APRNs, when they call, the nurse is not to call the supervisor until they've completed the S-bar. The supervisor then, when calling the doctor, will have the S-bar in hand, that's the goal, and that they're now giving them the information from the S-bar. The doctor's part, because they brought into it and they're part of the team, the medical director loves this program, is that they will be asking the nurses, do you have an S-bar? And if there's no S-bar completed, the doctor or the APRN is to tell the nurse, call me back once you've completed the S-bar. Remember, this is a team approach, so we're all working together, not to penalize each other, but to keep us all on the same page. Now when we talk about, so we included that with the care path and the change in condition file card. That was our guide to assist the nurses in making their decisions. In phase 2, when we went to phase 2, we looked at the hospital communication tools. Because we did this so early before the envelopes were rolled out, we had already rolled out envelopes. And Florence and I laugh about this because we're reviewing them. Because we looked at Doncaster and we had, ours were blue. We came up with blue, we said that was all colors. And we had the information printed directly onto the envelope. And in our attempt to assist the EMTs, we actually created a envelope for them that would have their information in the back, so that once the nurse filled that envelope, they would have no reason to open it. They didn't have to feel rushed that what if we don't know it, we say all the information is inside and it's not there. So it became a happy medium. The goal for us was to actually see if we could have the envelopes returned to us. That was the key for us to see, will it made it to the ER, will it make it back to us? And did they actually look at the envelope to see what things we were able to do at the health center without them having to be admitted? And then we start to look at the information, so we sent out the capabilities. And then in phase 3, as we move to phase 3, we were fortunate enough that we actually have pharmacy students who do their rotation at Cato Hitchcock at Doncaster. And they created for us and put in place our medication reconciliation form that we took from the Interact, and we also took from the information that the hospital wanted to make sure that now we would have a medication reconciliation form that we will be training the staff on. The last part is that we had to have a team approach to this. No one person can do this. If anyone thinks that I'll take this and I'll roll it all out and I'll have it all in place, they're not too wise, because it really takes a team to roll this out and to come back and look at it again. And one thing about this S-bar and looking at the tools that we're using, when we call the doctor and we're utilizing the form and we're saying to the doctor, he says to them, why didn't you call me the day before? You're telling me this happened to the patient the day before. I didn't get a call. And so what we're doing, the same way the doctor is telling the nurse, call me when you have the S-bar completed, the nurse is saying to the doctor, according to the best practice of using this S-bar, remember the doctors are supposed to have this information along with the nurses. We're all getting trained together. She can say, according to the chart we're to call you the next day. Remember, that's what these are for. When you look at the signs and symptoms of when to call, and when you look at the tool at the tree and it's telling you to call today or the next day, now that's empowering the nurse to say, I looked at this and the doctors have agreed. That's the big piece, is that they agree that they too will follow that form. And if they do that, you have everyone is on the same page and you have a complete form as to how you're looking at that patient. So what we have now is phase 4. We're doing all this thing, but now we need to actually be communicating with each other. And that's why quality improvement, looking at the hospital rates and tracking tools, and looking at our quality improvement tools for the acute transport. So I met with our medical director, and what we're putting in place now, as we're still working on it, is that we're reviewing this information on Mondays when we have our directors round. Meaning that if we have someone who had to be called the doctor and the SBAR was completed, we're making a copy of the SBAR, we're bringing it and having a conversation about that. If we have someone that a stop and watch form was completed, we're bringing that with us so that we can review it and see what can we do better. And if someone was sent out, we do have where the social service director is making that call within the 72 hours and 30-day follow-up to make sure that everything that we said we would do was being done. Remember, the whole goal for us is to decrease readmission rates to the hospital and decrease a resident having to go out to the hospital. So we're actually working as a team. Our team consists of the families, the CNAs, the nurses, the DNS, administrator, social worker. We have a navigator that goes cross campus, our staff development, quality assurance, the medical director, the APRN, the assisted living director, the nurses, the wellness director, the recreation, rehab director, and admission. We also have housekeeping and dietary, a part of our team. Because as we know, it takes everyone, not just clinical, but how many times have someone in dietary or housekeeping noticed some small changes within a resident because they talk to them every day. And so that's an invaluable tool for the stop and watch for them. So we did talk about the blue envelope that goes out to the hospital, and I just wanted you to see a picture of our stop and watch box that we use. And as I said, this is it's in progress, and we're continuing with our learning. Thank you.
A lot of work, and like LaShawn said, this is definitely a team effort, a team approach, which is what we have preached about Interact, and how it takes the whole village. It's going to take more than 1 month, 6 months, and how her staff is using the care path to actually empower the nurses to be more independent and to use their clinical abilities to work together with their physicians. Thank you so much.
A wonderful presentation. Thank you, thank you. We have a few minutes for questions. If anyone would like to ask questions of the team or of the Qualiline team concerning the decision support tools, in order to get on the phone, you need to hit *6 to let us, and that will open up your line, and then you can ask your question. So again, it's *6 to open up the line. Would anyone like to ask any questions of the phenomenal team?
Hi, this is Lori Giampaolo. I'm the Assistant Director of Nursing down at Gardner Heights in Shelton.
Hi.
I very much apologize. It's not a direct question. I really enjoyed it. It's my second Interact. I just got back in June. And my only thing, I just wanted to let you know, our computers were down, so I was not able to sign on. But I listened on the phone, and I have hopefully printed out everything that you gave, and I think it was fantastic. All the information, and I will pass it along. My director and administrator are out of the building today.
So I was filling in, but I just wanted to let you know I was on by phone and was unable, unfortunately, to get on through the internet. Apparently, we had a problem at our corporate office.
Okay, thank you so much. And we have it registered that you have participated today. Thank you.
And thank you so much. I'm looking forward to more. It's really interesting, and it looks like it's going in a really good direction. Thank you.
You're welcome. And you'll be able to go on our website in about a week to view the actual webinar if you missed it today.
All right, great. Thank you so much.
Okay, star 6 to ask a question for either the Qualidan team or the Caleb Hitchcock at Doncaster team. We are so thrilled to have them in the house.
Hi, it's Sheila, the Director of Nursing at Samenbrook Center.
Hi.
Just a quick question as to where we can download the care path and the cards. I may have missed that, and I apologize, but I'm just curious as to where we can get that information.
You can go onto the Interact website, www.interact2.net.
And it'll be right there.
Yes, it's in the chat box.
Yep, you're going to then click on Tools. You have to agree that you are going to abide by all the rules of Interact, that you're not going to manipulate the forms in any way, and then it will be in the decision support tools down at the very bottom of the screen for the tools.
Excellent. Thank you so very much.
You're very welcome. Great question. Any other questions? Star 6.
Hi, my name is Carolyn. I'm calling from Middlesex Healthcare. I'm the new Director of Staff Development.
Hi.
Hi. So, I actually, oh my goodness, it's been a long day. I was just wondering, so the care paths that are available, are these all nursing measures that can be implemented without an APRN or an MD approval, or do I need to bring them to my either medical director or my APRN to have them sign off to say, yes, this is what I want you to do in case that situation comes up?
You should bring it to your medical meeting and have your medical director as well as the director of nursing agree that the guidelines are what will work for your facility. Because what we're finding, and Interact actually agrees to this, is that those are their suggestions of what the guidelines should be, let's say for temperature or blood pressure. But if your facility and your corporate body has either stricter guidelines or something that works better for you, you can actually go with your own guidelines. That part of those decision-making tools, you can actually change to meet the needs of your facility. But definitely get your medical director and your APRNs involved in making that decision.
Yeah, because a lot of us are tied with what our corporate policies are. So it is nice to have something, that's easy to read and just to follow along, especially because we are hiring a lot of new nurses, a lot of new who need that.
Absolutely.
Especially because, honestly, what are the shifts that all of these nurses work? It's going to be second shift and third shift, and there's not going to be many people there to guide them.
Right, and this is tools that's already built for you, so you don't have to develop it yourself. You just need to tweak it to meet your needs.
Awesome. Thank you so much.
Thank you for the question.
Excellent question. Okay, so we have 10 of, so we're going to sign off to those nursing homes that are not part of a state-specific intervention. So for the Connecticut nursing homes that have signed the agreement, the participation agreement with the New England QIN-QIO, please stay on the line. The New Hampshire nursing homes, Joyce has turned over the session today to Tim Boyd, and his phone number is 1-855-309-6568, and the pass code is 861-864. So you're going to jump off this call and then jump on to, if you have any questions or comments, to talk with Tim. And everyone else, we wish you well. Morgan, do you have you want to sign us off?
Yeah, just to let you guys know, when you close out of the webinar today, you will be directed automatically to the evaluation for today's webinar. If you could please fill that out, we would greatly appreciate it. If you don't have a chance to fill it out right now, or you're sharing a computer with somebody else, you will receive an email tomorrow with the link to that evaluation. So if you could make sure to fill that out for us, we want to make sure that we're providing you with meaningful programs. The PowerPoint presentation for today is already posted on the website. It was also in the email that was sent out earlier today. The recording of the webinar and the transcript will be added to our website within the next week, so you guys can go there to download it and share it with anyone else in your facility. And our next Interact webinar is going to be on October 28th, and it will be kind of a series conclusion and recognition webinar, so we hope you guys will all join us for that one as well.
And we would like to recommend that you invite your Director of Nurses as well as your administrator to this celebration so they can hear best practices and we're going to be inviting other nursing homes to share best practices and lessons learned and challenges that they still are up against on this rollout. So please join us next month, October 28th at 1 o'clock. So the Connecticut nursing homes, please stay on the line. New Hampshire, you have a phone number that you can call into to talk with Tim, and everyone else, have a great day. Thank you.
Thank you.
Back on Connecticut nursing homes. Welcome, welcome again. This is Carol, but I still have all the team, Sheila, Florence, and Caleb Hitchcock at Doncaster team in the room, in the house. And so, again, we spend the next, we have about 12 minutes now to review last month's homework, discuss some successes and barriers, and then also discuss next month's homework. Again, it's homework to help you roll out Interact. That's why we put it in place when we started this back in February. Can you believe that? We started this in February. But when we started working on developing this program actually back in December, we felt it would be helpful for the nursing homes to have some scheduled homework that the team can work on for the month. So they're just not sitting there holding their hand saying, what should we be doing, what should we be doing? So that's why this homework has been very important to help with the rollout. Now, many of the nursing homes have been calling us about the participation certification. Again, certificate. It's a certificate. Thank you, Florence. I say it wrong every month. So in order to get a certificate, a participation certificate from the New England QIN-QIO and your community. So it's going to be signed by the both of us. You have to have at least participated in 7 of the 10 webinars. We have 1 more left. Today is number 9. Along with sending monthly readmission data to Qualidine for at least 3 months. And as I mentioned, for the past 2 months, we're not sharing this data with anyone, except that we want to make sure that you're starting to look at your data. So by sending us 3 months worth of data gives us the feel that, yes, you are collecting your data and you're looking at it. Without data, you don't know which direction to go. So we have 17 nursing homes out of the 91 that have entered data into Advancing Excellence and that have over 3 months worth of data in there. So thank you for those 17. And then just this morning, we have sent out to the administrator who signed the participation agreement with us back in December, we have sent them a readmission grid to have them fill in at least 3 months worth of data. And that grid went along with some instructions. So please talk, if you are the team lead, but you didn't sign the participation agreement, please talk to your administrator, whoever signed it, because they got that email this morning. Or you can always give us a call, either myself, Florence, or Sheila, and we will send you also the grid with the information, because we need to get this information back to us. with that being said, this is the readmission tracking tool. I went over it last month, but this is the grid that was sent to you just this morning. And then if you needed to follow up, let's say you missed one or two webinars, and you wanted to be at that 100%, you could always review a webinar, and we are now tracking whoever goes on our website. This is the link to our website, and you can click on events and then previous events to find the webinar you're missing. And each of your community leaders have the grid of what webinars each nursing home has missed. So give them a call if you don't know, or you can always give us a call. Go ahead.
And we're no longer accepting new participation agreements.
Yes. Okay. So this was the homework from last session. You are to review the advanced planning tools and the communication guide. You are to discuss how and when your staff nurses, your social workers, your supervisors, your leadership, your medical directors were going to be educated on use of the tools and decide which unit was to begin to use these tools. You were going to develop, the team was to develop a timeline of when this was going to occur, and when was the first tools going to be rolled out. And then with any time you roll out a new tool or a new process, you always should debrief right after the tool is used. So it lets the staff talk about what worked, what didn't work, and also empowers the other staff members to say, I can do this. It can work. So please, debriefing is as important as the education itself. So with that being said, I would like anyone to chime in and how things went this past month using the advanced care planning tools of the Interact program. How was it talking to your medical director about the tool implementation, or did you any best practices that you would like to share but using the tool for the first time? And again, *6 to open up your phone so we all can learn from best practices or lessons learned. Anyone would like to share best practices? How about our guests, when you were working with the staff using the advanced care planning tools?
Well, one of the things that we did was, because we had also a transition team.
Okay.
So within that transition team, that's the cross-campus community that we're all talking together, is that the social worker, that's what I'm saying, where they're taking it. What we're doing now we know the point where we're growing is, we know everyone is implementing that. Now we're working on bringing all this information back and reviewing it. We know when we have the care conference, our social director of social services is talking about, they've met with this family, they've talked about what their wishes are, they've gone over the advanced directive. And we've actually had a situation where that actually came into play, where we actually had to meet, and no one really understands how important it is, because there may be an issue comes up that you actually have to deal with when it comes to the court. So these are not just so that you know, and that you don't want to wait till something is happening to your resident, that they're in the midst of actively dying, now to look, or there's a question that they're on that cornerstone and that question hasn't been answered. So when you brought up about bringing this up in the quarterly meeting, that's why it's being done, and I'm glad when I listen, and it does help. It helps to remind you that you are doing that. Or if you're not doing one part, like you said about the debriefing, to now debrief. We were good about making sure we rolled out everything. Now we want to make sure we come back and talk about it.
Excellent. Excellent. Thank you. Thank you very much. Anyone else on the phone? *6 if you care to share with your colleagues. This is really a very important part of our time together.
Hi, this is McLean.
Hi, McLean.
Diane.
Oh, welcome.
Thank you. We just wanted to say we've been using the SBAR and the red envelope and things like that pretty regularly now. We have some good processes. What our next step is to do is really set up a debrief with the nursing supervisory team to really just talk about the tools. We're using them in the moment in those emergent situations, and we want to kind of have a sidebar discussion and debrief about the use of the tools when we're not in an emergency situation, because sometimes it feels a little stressful in that moment. So that's our next step.
Excellent. Thank you. Thank you for sharing that. Excellent. Okay, I've just been told that we're almost at the top of the hour, so the homework for next session, for this next month, is more, we want you to look at your care path, and we want you to look at the file cards, but we would really like the team, that transitions team, or if you call it the Interact team, to look at the Interact implementation checklist. Now, this was part of the slides. It was in the email with the slides, so you can download it from the email, or you can also download it from the Interact website. But this is what it looks like. And what we would like you to do is go through the checklist to say, as a team, yes, we've implemented it, and it's going well, or we've talked about it, we just haven't implemented it. So again, this is a good tool and each of these areas need to be part of the Interact Quality Improvement Program. So please sit down as a team. It should take you a while, book out at least an hour to go through this implementation checklist. And next month, we are going to be asking nursing homes, the Connecticut nursing homes, to review how this review went and what are your next steps. So please be ready to share your findings next month. So with that being said, I've been told I'm now 3 minutes over. My bad. But thank you so much for your great participation this month. And thank you, Caleb Hitchcock from Doncaster. You guys outstanding at Doncaster. Excuse me. So we'll see you all next month. And please invite your DONs and your administrators. Okay, the medical directors. Please, because they need to hear all the good work that's being done. And because as we have learned today, they are part of the team and a very important part of the team. So thank you so much and have a great day. Bye-bye, everyone. Bye.